And we're continuing on with the pharynx and the esophagus. So we talked about the pharynx and the respiratory system. This is a muscular funnel within the oral cavity that leads to the esophagus. So it is a passageway and it connects the nose or the nasal cavity to the larynx. It has a layer of longitudinal skeletal muscle that's going to be deep, and more superficial, there's going to be some muscles that form pharyngeal constrictors. There is a superior, a middle, and an inferior. And those will take turns contracting or constricting, which will force food downwards during swallowing. And when we are not in the process of eating, the inferior sphincter, or sorry, not sphincter, constrictor, that constrictor, which is the same thing as the upper esophageal sphincter, that's going to remain contracted, and that's going to keep air from going down into the esophagus and will direct the air into the trachea. The pharynx has 3 different regions. So this structure here includes the whole pharynx. The portion of the pharynx that is by your nose, we talked about more in the respiratory system. It is not part of the digestive system. The oropharynx is the portion that is by the mouth. You can see this large tongue here, so we know that this area is the mouth and the oropharynx. And then we have the area that is by the larynx, which is the laryngopharynx. So that's below the oropharynx and it's going to be connected to the esophagus. Here we have those regions in X-ray. You can see the nasopharynx, the oropharynx by the tongue, and then the laryngopharynx. The esophagus is a long, straight muscular tube. So you can see the pharynx here. That's where the esophagus is going to begin. It's going to continue that tube, and it's going to be posterior to the trachea. Remember, the trachea is the windpipe that we looked at in the respiratory system. And so the esophagus is going to begin just at about the level of C6 in the vertebrae and right about where the cricoid cartilage of the trachea begins. And then it will extend down from that pharynx and travel towards the stomach. When it does, it's going to pass posteriorly to the heart. So you can actually see the esophagus crosses the arch of the aorta. And it's going to have to pass through the diaphragm. So where it goes through the diaphragm, that's called the esophageal hiatus. And then we have the lower portion of the esophagus where it meets with the stomach here. This area of the stomach is referred to as the cardia region. And there is going to be a sphincter, which is a round circular muscle that allows passages of materials. So food is going to have to pass through a sphincter to get out of the esophagus and into the stomach. And so that sphincter is called the lower esophageal sphincter. It's also referred to as the cardiac sphincter. And that will allow food to pass through. But typically that sphincter is closed, and food will have to pause there because of that constriction. But we do want that valve or that sphincter closed because we don't want stomach contents to regurgitate back up into the esophagus. And that sphincter is going to protect that delicate esophageal mucosa from the hydrochloric acid that is inside of the stomach acid. And this is actually what heartburn is. My poor husband, he has heartburn so bad, and every doctor always recommends proton pump inhibitors, which those are so terrible for you. Really, really bad to use long term. But what happens is that sphincter, or is for some reason, it either is loose or it opens when it shouldn't, and it allows that hydrochloric acid to get into the esophagus, and it literally burns because it's acidic. It starts to burn your esophagus. Well, if you look at the anatomy, your heart is right here, right where that burning sensation's located. So that's why it literally feels like it is your heart that is burning and why it's called heartburn. The epithelial tissue within the esophagus is still going to be stratified squamous because there's some abrasions that can happen, so we need some protection. It's also non-keratinized, so it doesn't have that hardened keratin protein within those cells. The epithelial tissue is also going to have ducts from the submucosa layer that has the esophageal glands that are going to secrete mucus into the lumen of the esophagus. And that will kind of help lubricate the esophagus to help food move through. It's also very deeply folded into these longitudinal ridges when it's empty, but these folds can expand to compensate larger boluses. The upper third of the esophagus is going to be skeletal muscle. The middle third will be a mix of skeletal muscle and smooth muscle, and then the lower third will only be smooth muscle. And it's going to meet the stomach at approximately T7 in the vertebrae. This is actually a really good picture because you can see those two layers, the inner circular layer and the outer longitudinal layer. Here we have an approximate location of the esophagus, and then we can see in the cadaver, we have the lungs that have been removed, the heart's been removed, and the trachea has been removed too. So you can see the esophagus, and then you can see how it passes through the diaphragm, through that hiatus. Here we have a scopic image of the esophagus, and you can see it's kind of pink, slimy looking, and you can see those longitudinal folds that can expand to compensate larger boluses. Here we have the layers of the esophagus. We have the lumen, which is here in the middle, and so the most deep layer that comes into contact with the bolus or the food is going to be the mucosa layer. And then we have the muscularis layer as well, and then we have the submucosa and then the muscularis externa. That's also referred to as the adventitia layer. So don't get that muscularis external mixed up with the muscularis mucosa. This is a nice diagram that shows those muscle layers. So again, we have the longitudinal muscle layer, and then you have the circular muscle layer that is actually going in a circle. So you can see the different directions of the fibers of those muscle layers. And then here we have a histology image of the same thing. We have the circular layer that's going like along the length of the slide. And then we have these cutout bands here that are the longitudinal muscles. Deglution is the fancy way that we say swallowing, and that occurs in three major phases. There is the oral, also sometimes referred to as the buccal phase. There's the pharyngeal phase, and then the esophageal phase. So the phases are named for where the bolus or food substance is located. Chewing is mastication. During that process, the food is going to start to get mixed up with the saliva, and we now call that food lump a bolus. So the bolus is located in the oral cavity, so we refer to this as the oral phase, and this is when the tongue is going to collect the food, and it's going to press it against the palate, and it's going to form this ball, or a bolus. And then it's going to get forcefully pushed posteriorly into the pharynx by the tongue. And this is a consciously controlled process, right? We can control when we swallow. When we do swallow, well, before we swallow, food is going to accumulate in the oropharynx in front of the epiglottis. So we learned about the epiglottis during the respiratory system. But so when the food's in the mouth, we can still breathe and chew, right? So the epiglottis is open. And then when we swallow and we push that food back into the pharynx, that is also going to push the epiglottis closed, and it's going to cover the larynx. So now we have the opening to the trachea closed off. So food isn't going to be able to get into the lungs. And as that bolus is pushed back, the uvula is going to fold upwards and it's going to block off the nasal cavity. So that way food doesn't get up into our nasal cavity. And it will force the bolus to slide around the epiglottis and go into the laryngeal pharynx. So this is the portion of the pharynx that's by the larynx. Here we have a good diagram from your book. You can see the nasal cavity here, the oral cavity here. There's those palates, the vestibule. We've got that large tongue. And then here's the hard palate, the soft palate, and the uvula along with that palatine tonsil. And then here's that epiglottis. And so when the bolus is swallowed, the tongue pushes that bolus backwards. That forces the epiglottis up and the, I'm sorry, not the epiglottis, the uvula up and the epiglottis down, and it will push the bolus into the laryngopharynx. So now we're in the pharyngeal phase. The bolus is located in that location. So we have that epiglottis that is blocking the larynx, and the uvula is blocking the nasal cavity, preventing food and drink from re-entering the mouth or the nasal cavity. While this is happening, we have infrahyoid muscles that are pulling on the larynx, and they pull that larynx up to meet the epiglottis, and that covers that laryngeal opening. The vocal cords will adduct to close the airway, and that is also going to cause the esophagus to widen, right? So we're going to have constriction of the airway and widening of the esophagus, and that's going to help direct the food into that proper location. This will cause food to travel to the esophagus instead of into the respiratory system, and that bolus will be driven downwards by constriction of the upper pharyngeal constrictor, then the middle pharyngeal constrictor, and then finally the lower pharyngeal constrictor. So here we have the second phase, the pharyngeal phase. You can see that the vocal cords and the epiglottis are blocking that respiratory pathway, and the uvula is blocking the nasal cavity, while the pharyngeal constrictors are going to push the bolus into the esophagus. When this happens, we are now going to push the bolus into the esophagus, and so we are in the esophageal phase, the third phase. And this is where we're going to have peristalsis occur. That bolus is going to start to be propelled down the esophagus using wave-like muscle contractions. So you'll have constriction of the inner circular muscle layer, and that's going to prevent the bolus from being able to go backwards. And then when the longitudinal muscle layer contracts, that's going the length of the esophagus, that is going to push and propel the food down the esophagus. When you're standing or sitting upright, food and liquid can just drop through the esophagus by gravity faster than peristalsis can keep up with. So peristalsis is going to ensure that you can swallow regardless of your body position. Little fun facts that we have liquids that will actually reach your stomach in 1 to 2 seconds, while food in a bolus form takes about 4 to 8 seconds. When the bolus does reach the lower end of the esophagus, the lower esophageal sphincter will relax to let the food pass into the stomach. And this is under control of the parasympathetic nervous system, the peristalsis contractions. So try to think about what actions are going to prevent the pharynx from forcing food back into the mouth or the nose. Well, the answer is blockage of the mouth by the root of the tongue, and then blockage of the nose by the uvula and that soft palate. This is a good picture showing the esophagus propelling the food down into the stomach, and then that lower esophageal sphincter opening to allow the bolus through. Here we have an upper GI or barium study. This individual or patient has swallowed some barium because it shows up on an x-ray, and we can see the pattern of constriction or contractions of the esophagus. And that's going to do it. So our next lesson will be on the stomach.